In this lecture, we're going to look at the shoulder region, specifically the axio-appendicular and the scapulohumeral muscles. So we're going to look at the shoulder joint and its range of movement, and specifically how the muscles enable the shoulder to move. The anterior and posterior axio-appendicular muscles. We'll then look at the scapulohumeral muscles and how some of these form the rotator cuff coming from the scapula to the humerus. We'll then look at the functional anatomy of these with their origin, insertion, and the movements that they can allow the shoulder to perform. So the anterior axio-appendicular muscles. What do I mean by axio-appendicular muscles? Well, these are muscles that run from the axial skeleton to the appendicular skeleton. So they run from the axial skeleton, the sternum, the ribs, the vertebral column, to the appendicular skeleton, which in this case is the upper limb, the superior appendicular skeleton, the clavicle, the scapula, the humerus. And here we can see the anterior muscles. We have a whole series of them. We have pectoralis major, we can see here. We can have pectoralis minor, we can see here. We've got subclavius, we can see here. And also we've got serratus anterior. We'll come back to that later on. What we can see is the pectoralis major muscle has a number of heads. Really, it's got two heads. It's got a clavicular head where it's coming from the clavicle, but the axio-appendicular part of it is where it's coming from the sternum and the costal margins of the ribs. We can see this muscle, this fan-shaped muscle, is running down towards the shaft of the humerus, and we'll see where it attaches on the shaft of the humerus, just within the intertubercular sulcus, but here not up in between the greater and lesser tubercles, quite distally down onto the shaft of the humerus. So we've got pectoralis major here. This is a large fan-shaped muscle that's easily visible once the skin of the anterior chest wall has been reflected. Clavicular head coming from the clavicle, and a sternocostal head coming really from the sternum and the costal cartilages. Reflect pectoralis major and we find we have pectoralis minor. We can see pectoralis minor here. Coming from ribs 2, 3 and 4, we have pectoralis minor running up to the coracoid process of the scapula. So here it's now important to remember those bony features I was talking about in the first lecture. We can see we've got pectoralis minor running up towards the coracoid process, and that lies deep to pectoralis major. Running underneath the clavicle, running from the first rib to that groove for subclavius that I spoke about again in the first lecture, on the inferior surface of the clavicle, we've got subclavius muscle we can see here. Running from the sternal aspect of the first rib all the way over to the clavicle. And here we can see these anterior axio-appendicular muscles. We'll cover serratus anterior in a moment. We can see that the pectoralis major muscle, as I mentioned, it has two heads, and this table really is going to detail their origin and insertion. It's then going to look at the nerve supply, and we can cover some functional anatomy here. But here with the pectoralis major, we've got the clavicular head and the sternocostal head. We can see where they're attaching, as I mentioned previously. And these are going to insert into the intertubercular sulcus, specifically the lateral lip of it, but not between the two tubercles. And the nerve supply to this muscle is via the lateral and medial pectoral nerves, and these are branches that are coming from the brachial plexus, which we'll see. Here we've got the specific root values, so the specific spinal cord segments that give rise to those nerves. The function of pectoralis major is it adducts and medially rotates the shoulder joint. So it adducts, it brings the arm back against the thoracic cavity, and it's also involved in medially rotating the shoulder joint. It also pulls the scapula anteriorly, so it protracts the pectoral girdle, and it pulls it inferiorly as well. So pectoralis major. Remember, here we can see pectoralis major muscle. Now we've got pectoralis minor. We can see pectoralis minor, like I said, coming from ribs 3 to 5, passing towards the coracoid process of the scapula. And this is innervated via the medial pectoral nerves. And again, we can see this is coming from C8T1 spinal cord segment. Pectoralis minor is important in stabilizing the scapula, so it holds the scapula against the posterior chest wall, and it also pulls it anteriorly and inferiorly, a similar function to pectoralis major. If we remind ourselves of subclavius, positioned inferior to the clavicle, we can see that it's running from the first rib and the sternum, the junction of those two, to the middle third of the clavicle, supplied by the subclavian nerve. It stabilizes and depresses the clavicle. We can appreciate that if we see it here, coming from the junction of the sternum and the first rib. This is going to be a solid, its origin, this is not going to move. And as its muscles contract, it is going to depress the clavicle. The final muscle I want to talk about is serratus anterior. And this is somewhat different from the previous muscles I spoke about that were coming from this more anterior aspect of the chest wall. Serratus anterior is coming from this lateral aspect of the chest wall, and it's passing backwards towards the medial border of the scapula. So here we can see the medial border of the scapula. Remember, this is the lateral border. And this serratus anterior muscle has got this nice serrated edge, which gives it its name. Coming from the ribs here, we can see rib 2, 3, 4, 5, 6, 7, 8, 9, running all the way along the chest wall. We can see it's running between the chest wall and the scapula. So this impression here is just a shading through the scapula. It runs between the scapula and the chest wall to attach to the medial surface. So we can see here serratus anterior coming from the external surface of ribs 1 to 8. We can see we have the fibers passing to the medial border of the scapula. See it passing in between the scapula and the posterior chest wall. It is innervated via the long thoracic nerve, and the long thoracic nerve is going to be running down in this direction. So we can see the long thoracic nerve running down in this direction. The long thoracic nerve coming from spinal cord segments C6 and C7. It's involved in protracting the scapula so it can pull the scapula forward and hold it against the posterior thoracic wall. This is important if you were to say push off from a wall. If you were leaning against a wall and pushing off, then you need the scapula to be anchored against the posterior chest wall. If that's anchored against the posterior chest wall, then you'll be able to move backwards. If it isn't, if there's damage, say, to the long thoracic nerve, then this serratus anterior cannot contract. It cannot hold the scapula against the posterior thoracic wall. And then when you push off, the scapula actually pushes out into the skin of the back, and you have something called winged scapula. So damage to the thoracic nerve via trauma, a knife attack into the axilla, or breast surgery, or removal of lymph nodes for cancer treatment, can damage the long thoracic nerve and lead to winged scapula. If we have a look at these in a more anatomical arrangement, then here we can see we've got pectoralis major here. We can see we've got serratus anterior sitting underneath it here. We can see that the fan-shaped pectoralis major is passing towards the arm. And we've got this muscle here, deltoid, which we'll cover in a few moments' time. But what we can see is that between pectoralis major here and deltoid, we have this deltopectoral triangle. And that triangle is important as it receives the cephalic vein. As we mentioned in the previous lecture, the cephalic vein passing up towards the auxiliary vein runs in the deltopectoral triangle. And here we have the formation of the deltopectoral triangle. So here we can see pectoralis major and we can see serratus anterior. If we reflect pectoralis major over here on this side of the screen, we can see here the reflected cut edge of pectoralis major. We can see its cut edge here as it's running down, attaching to the intertubercular sulcus. And we can see pectoralis minor. What we can see directly beneath pectoralis minor is a blood vessel here, another blood vessel here, and a yellow nerve. These indicate the axillary artery and the axillary vein and the brachial plexus. And these are running deep within the axilla, running deep to pectoralis minor. We can see them running along here. And we'll look at these in the next lecture. So here we can see pectoralis major. We can see once it's reflected, we can see pectoralis minor. And here we can see some of the digits of serratus anterior. If we now look at the posterior axio-appendicular muscles, we can split these into two groups, a superficial and a deep group. Here we can see on this side of the screen the two superficial muscles I want to talk about, trapezius and latissimus dorsi. We can see trapezius here has both a superior or a descending part. We have trapezius here forming a transverse or a horizontal part, and we have trapezius here forming an ascending or a more inferior portion. Three parts of trapezius: a superior, we call it a middle, and an inferior portion of trapezius. We see it's running from the midline, from the spinous processes of the vertebrae, and also from a structure called the nuchal ligament that's coming from the occipital bone. We can see it's passing towards the spine of the scapula, as we'll see. If we move over, we can see another superficial muscle, and this is latissimus dorsi, a large flat muscle that again is coming from the spinous processes of the vertebrae, both thoracic and lumbar vertebrae, and also this white membrane here, which is the thoracolumbar fascia. And this muscle passes up towards the intertubercular sulcus. It also attaches to the intertubercular sulcus of the humerus. We can see it passing up in this direction. So these are the superficial muscles. We can see we've got a descending, transverse, an ascending part of trapezius, or a superior, middle, inferior part, and here we can see their specific origins. The nuchal line and external occipital protuberance for the descending part, the nuchal ligament for the transverse part, and the spinous processes of these vertebrae here. And we can see that the external occipital protuberance, the nuchal ligament, and the spinous processes. And they're passing towards the spine of the clavicle, attaching to the lateral third of the clavicle and the spine of the scapula. So these are attaching to this region. The nerve supply is quite unique. It's coming from a cranial nerve. The spinal accessory nerve is cranial nerve number 11. So damage to the cranial nerve 11, the accessory nerve, gives an inability to elevate the scapula. It also receives innervation from spinal nerve C3 and C4, and this is thought mostly to be for proprioception, which is that positional sense. So these nerves carry information about the level of contraction within the muscle, tendon, and the Golgi organ of the muscle, allowing the central nervous system to know how much that muscle has contracted and therefore where it is in space. The function of these parts of trapezius, so the descending part helps to elevate the scapula, the transverse part helps to retract, pull the scapula backwards, and the ascending part helps to depress the scapula. So important movements of the scapula. Working together, the descending and ascending parts help to rotate the scapula superiorly. Latissimus dorsi, we can see it's coming from those bony regions that I mentioned, and it's passing to the intertubercular groove, specifically the floor. It's innervated by the thoracodorsal nerve, and this originates from spinal cord segments C6 and C7. It's important in extending, adducting, and medially rotating the shoulder joint. So latissimus dorsi is important in extending, adducting, and medially rotating the shoulder joint. If we then look to the deeper muscles, we can see we've got two rhomboid muscles, minor and major, and levator scapulae. And we just go back to the previous slide to see these. Here we can see rhomboid muscles running from the spinous processes of the cervical and thoracic vertebra, and they pass towards the medial border of the scapula. We can see we've got two parts to the rhomboid muscles. We have rhomboid minor, which lies most superiorly, and we have rhomboid major, which lies inferiorly. And sometimes you can make out a separation of these muscles, but in most cadavers, the separation is actually quite difficult to see. But you have rhomboid minor and rhomboid major. Here we can see passing upwards towards the skull, we have levator scapulae, and that's important in helping to, as its name suggests, elevate the scapula. So we can see rhomboid minor and rhomboid major. We have the minor coming from the nuchal ligament and really the spinous processes of those vertebrae, and major coming from inferiorly, so coming from spinous processes of the thoracic vertebra inferior to C7 to T1, coming from T2 to T5. But really this runs as one block of muscle. The minor one inserts to the superior aspect of the medial border, and the major one inserts into the inferior aspect of the medial border of the scapula. Both of these muscles are supplied by the dorsal scapular nerve coming from C5, and it's important in being able to retract the scapula, so pull the scapula backwards, and also rotate it inferiorly. So rotate the scapula inferiorly, which serves to depress the glenoid cavity. Levator scapulae is running from the transverse processes of C1 to C4. That's where it's coming from, and it runs down to the superior angle of the scapula, so that when this muscle contracts, we can see its origin here. When it contracts, this distance is going to be shorter. This is going to stay where it is. It's going to remain stable, which results in the scapula moving upwards. So we're elevating the scapula. It runs to the superior angle of the scapula, and it's innervated via the dorsal scapular nerve, which comes from the fifth cervical spinal cord segment. It elevates the scapula and is also involved in rotating the scapula inferiorly, again depressing the glenoid cavity. So these muscles can work together in that sense. Okay, now let's move on to what are known as scapulohumeral muscles. These are muscles that are running from the scapula and passing towards the humerus. We can see we have a whole series of them that are running from the scapula to the humerus. We have deltoid, we have supraspinatus, infraspinatus, we have some teres muscles, teres minor, teres major, and we have subscapularis. And we can see we'll go over their various attachments and functions. So let's start with deltoid. We can see we've got the deltoid muscle here coming from three different parts of the appendicular skeleton. We have the clavicular part, we have the acromial part, and we have the spinal part. So we have the anterior, we have the middle, and we have the posterior part of the deltoid. And these are all running together to the deltoid tuberosity, which remember we saw on the lateral aspect of the humerus. The deltoid, the anterior part, comes from the clavicle, the lateral part comes from the acromion, and the posterior part comes from the spine of the scapula, and they all converge down onto the deltoid. We can see that in this table here. Clavicular head, acromial head, spinal head, coming from those places. Runs the deltoid tuberosity of the humerus on the lateral surface, and it's innervated via the auxiliary nerve, and this comes from C5. The clavicular head is important in flexing and medially rotating the shoulder joint, so it flexes the shoulder joint. It's important in medially rotating, so turning the shoulder joint internally. The acromial head is important in abducting the shoulder, so moving the arm outwards. And the spinal head extends and laterally rotates the shoulder joint. So because of the wide attachment of the muscles, their widespread origin, they can have a number of functions. This one is important the ability for the acromial head, this middle part of deltoid, to abduct the shoulder, because this works alongside supraspinatus. We can see here in the table, supraspinatus helps to initiate abduction. So the initiation of abduction is not actually carried out via deltoid. The initiation of abduction is carried out by supraspinatus. It then assists deltoid when it takes over abduction. So starting abduction is supraspinatus. Deltoid then carries on abduction beyond the first initial 15 degrees of abduction. We can see that here. Here we have supraspinatus. Supraspinatus running from the supraspinous fossa of the scapula. Supraspinous fossa, remember, above the spine of the scapula, passes towards the humerus, specifically passing towards the greater trochanter of the humerus here. When this muscle contracts, the scapula is going to remain stable and the humerus is going to move outwards. It's going to abduct. So it's going to move in this direction, move outwards. It moves the first 15 degrees via the action of supraspinatus, and then the middle portion of deltoid carries on the movement of abduction. If we now go to other muscles, other scapulohumeral muscles running from the scapula to the humerus, we find we have a muscle coming from the infraspinous fossa that's passing from inferior to the spine of the scapula, and that passes also to the greater trochanter of the humerus. We then find we have teres minor and we have teres major. All these muscles running from the scapula to the humerus. We can see this is on the posterior aspect of the humerus, and we also have muscles which are on the anterior surface of the humerus. We have a muscle on the anterior surface of the scapula. And this muscle in between the scapula and the chest wall is subscapularis. Subscapularis, we can see here, is running towards the lesser trochanter of the humerus, the lesser tubercle, of the humerus. We can see the lesser tubercle receiving subscapularis. So if we look at the detail of these, then here we can see infraspinatus. We can see infraspinatus originating from the infraspinous fossa, and it passes to the greater tubercle of the humerus. This is innervated via the suprascapular nerve. We can also see we have teres minor passing across from the lateral border of the scapula and the middle portion of the infraspinous fossa. We can see it's passing again to the greater tubercle. And what we have is we now have three muscles that are going to the greater tubercle. We have the supraspinatus, which is going to the greater tubercle. We then have the infraspinous going to the greater tubercle. We have teres minor going to the greater tubercle. And these go to specific parts of the greater tubercle. We can see the supraspinatus passes to the superior facet on the greater tubercle. We can see the infraspinatus passes to the middle facet, and teres minor passes to the inferior facet. So pass to specific regions of the greater tubercle. They don't all pass to the same place. They pass to specific regions. Teres minor is innervated via the auxiliary nerve. Remember, we saw that supplying deltoid. These two muscles, infraspinatus and teres minor, help to laterally rotate the shoulder joint, and they hold the head of the humerus in the glenoid cavity. And this is really important. They help to hold the head of the humerus in the glenoid cavity. I mentioned previously that these muscles, that the glenohumeral joint was relatively weaker compared to, say, the hip joint, allowing for greater range of movement. But what actually stabilizes the joint, as well as some ligaments, are these muscles passing from the scapula to the humerus, and they help to stabilize the joint. They're known as rotator cuff muscles. Here we can see these rotator cuff muscles, or some of the rotator cuff muscles, infraspinatus, teres minor, and subscapularis. What we could add on to here is supraspinatus as well. And there are the four muscles that form this rotator cuff: supraspinatus, infraspinatus, teres minor, and subscapularis. And they form this cuff around the humerus, around the head of the humerus. Teres major here doesn't. Because that attaches to the shaft of the humerus lower down, it doesn't actually form this rotator cuff. Here we can see teres major running from the lateral border of the scapula. We see it running from the lateral border of the scapula here, near to the inferior angle and passing towards the shaft of the humerus. Specifically, it attaches to the intertubercular groove, the medial lip of the intertubercular groove, and here we can see it's innervated via the lower subscapular nerve. It adducts and medially rotates the shoulder joint. So teres major is an adductor where deltoid and supraspinatus were an abductor. Teres major helps to adduct and also medially rotate the shoulder joint. Subscapularis is coming from the subscapular fossa. It's running to the lesser tubercle. So where the other three rotator cuff muscles are running to the greater tubercle, this runs to the lesser tubercle of the humerus. Innervated via upper and lower subscapular nerves, it's important in medially rotating and adducting the shoulder joint. So with adduction and medial rotation, it works with teres major, but it also helps to hold the head of the humerus in the glenoid cavity. And this feature here, holding the head of the humerus in the glenoid cavity, means it's part of the rotator cuff. And here we can see those rotator cuff muscles in their kind of anatomical orientation. We can see here we've got the shoulder joint. We can see it's an anterior view on the right-hand side. So the chest wall has been removed. Here we can see it's anterior view, so it's on the anterior surface of the scapula. We have subscapularis muscle. Subscapularis muscle passing towards the lesser tubercle. Here, coming from the posterior surface of the scapula, we can see teres major. See it here. But we see it's running to the medial lip of the intertubercular groove alongside latissimus dorsi here. They share a similar insertion. But because teres major is not passing towards the head of the humerus, it's not a rotator cuff muscle. Here we can see that subscapularis is. On this posterior surface, we can see we have supraspinatus. We can see that just here. We can see that various parts of deltoid have been cut, have been reflected, so we can see deep to deltoid, where we then have supraspinatus, infraspinatus, and teres minor. And these are running towards the greater tubercle. Remember the greater tubercle having those three facets, superior. Here we can make out the middle, and here we can make out the inferior. Remember, supraspinatus passed to the superior facet, infraspinatus passed to the middle facet, and teres minor passed to the inferior facet. So we can see these on this posterior view. We can see the muscles originating from the scapula and forming this cuff around the head of the humerus. So all of these muscles except supraspinatus are rotators of the humerus. All of these except supraspinatus are rotators. But supraspinatus still runs in the direction that forms this cuff around the head of the humerus, so acting as a rotator cuff. But important to remember that supraspinatus just abducts. Tendons of these four muscles blend with the joint capsule and form a musculotendinous sheath, and this surrounds the glenohumeral joint. Tendons blend with the joint capsule. You can see these tendons here, and they help to protect and stabilize the joint. It's the tonic contraction, so these baseline contractions of these muscles, that hold the relatively large humeral head against the shallow glenoid cavity. So the shallow glenoid cavity and the large humeral head is held in position via these muscles, these rotator cuff muscles. So in this lecture, we've looked at the anterior and posterior axio-appendicular muscles. The anterior ones, pectoralis major and minor, subclavius and serratus anterior. And then posterior muscles, split into those two groups, superficial and deep. Trapezius and latissimus dorsi in the superficial, levator scapulae and rhomboid major and minor in the deep. We then looked at the deltoids, supraspinatus, infraspinatus, teres major and minor, and subscapularis muscles that form the scapulohumeral muscles. Specifically mentioning the rotator cuff, which is supraspinatus, infraspinatus, teres minor, and subscapularis. We then looked at their origins, their insertions, and their movement.